cognitive behavioral therapy is a form of psychological treatment that may be effective for a wide range of mental health conditions and life challenges. We are very fortunate today to have as our speaker Dr. James Korman, a clinical psychologist and chief of behavioral health and wellness at Summit Health. Dr. Korman is a fellow of the Academy of Cognitive Behavioral Therapy. He oversees a large department of mental health professionals who utilize this technique and is involved in the training of psychologists and therapists in the technique. He is a certified cognitive therapist and trainer through the Academy of Cognitive Therapy and has also been involved in supervising medical residents, nurses, occupational therapists, social workers, and counselors. Dr. Korman is a graduate of Roosevelt University in Chicago and of the Chicago School of Professional Psychology. We welcome Dr. Korman to the Old Guard.
What I'm hoping to be able to do is give you an understanding of what is CBT. We got it? Okay. All right. So just use the arrows. Okay. It's over here. So I'm going to spend a little time talking to you about what is CBT, right? How does it explain human behavior, right? Because if you can't explain human behavior, how can you treat it? You have to have an understanding. How does it affect change? And what is it used for, and what does it look like? So I'll show you a couple of strategies that we typically use in CBT. So to start with, the first thing we have to do is we have to kind of think about this. Here you got two people on a roller coaster. Same situation, same experience, right? And you can see the person on your left is having a blast, right? Best time in the world. And you can see the person on your right is pretty sure they're gonna die. Why? Why do you have two people having the same set of circumstances and having two very different reactions? Or how about this? You've got two people who are invited to a party. One person is so excited, can't wait to get there, meet new people, make new friends. And then this person is dreading it, right? I don't want to go. I'm going to make a fool out of myself. People are not going to like me. Why? Same party, right? So what is that all about? So what CBT attempts to do is tries to give us an understanding of this, because it is a paradigm that tries to explain, why do we see the world the way we do? Why do we have the thoughts that pop up into our minds when we're experiencing things? Why do we engage in the behaviors that we have, and why do we have the feelings associated with all of those things? We also know that it is a set of scientifically validated interventions, which I think at this point have thousands of randomized controlled trials showing its effectiveness in a wide range of psychological and psychiatric disorders. It also can be used as a standalone treatment, or it can be used in combination with other treatments such as psychiatric medications. From a treatment perspective, CBT is a focused form of psychotherapy that stipulates that disorders involve dysfunctional thinking, dysfunctional and distorted perceptions about ourselves and our place in the world, and also behaviors. And if we correct these distortions and these dysfunctions, we can get symptom relief and enduring change. So, to put it more simply, CBT believes that it is not the events in people's lives that are causing them problems, it's how they think about those events that causes them problems. That's why you can have 10 different people, same event, and you get those 10 different reactions, just like our person on the roller coaster and the person going to the party. We also know that the way that people think about things has a huge impact on their feelings, on their physical sensations, and on the actions that they take. So let me give you a couple of examples just to, bring this home and have you understand it a little more. So this actually is coming from somebody I treated not too long ago, but, let's assume that I get up for a second and I have some chest discomfort. So I wake up in the morning, I have a little chest discomfort, right? It's a little tight, a little achy. Maybe when I breathe in, I can't breathe in quite as deeply. And so when I get those symptoms in the morning, I get an automatic thought. Now, that automatic thought pops into my head, and we call them automatic because you don't ask them to be there, right? You don't get up in the morning and say, I think I'll think something today, right? It just pops into your head. And one of the hallmarks of an automatic thought is it's accepted as true. So we get these thoughts, they pop into our heads and we just accept them. And so I have this bit of chest discomfort, I wake up in the morning and I get this automatic thought that says, geez, I wonder if I'm having a heart attack. So as soon as I have that thought, what happens, right? All of a sudden, I start to become anxious. Then I start to focus more on those symptoms. Then I start to maybe poke and probe those symptoms. They start to bother me more. They feel more intense. So because I'm anxious and I'm worried about this and it's feeling worse, what am I going to do? I'm going to go and figure out whether I'm having a heart attack. So I'm going to go to that bastion of truth, the internet. And I'm going to look up my symptoms, and of course I'll ignore anything that suggests I'm not having one. And of course I see all this information that says, oh my God, I'm having a heart attack. And so what happens, right? I start feeling worse. I get more anxious. I get panicked. These symptoms start to feel worse and worse. And what happens? I'm either calling 911 or I'm going down to the emergency room. Now, take this same situation. Get up, have a little chest discomfort, it's bothering me a little bit. And I get an automatic thought that pops into my head, geez, I must have slept funny, right? I must have swung my golf club a little bit too hard or something, right? So it hurts a little bit. So what's gonna happen? Nothing, right? I'm not gonna get anxious, I'm not gonna feel these symptoms anymore. And what am I gonna do? I'm probably gonna do a little stretching, right? See if I can work this thing out. So again, you can see same set of circumstances, very different reactions. And by the way, just so you understand this, I set this up very linearly, like there's a situation, a thought, a feeling. That's not really true. They interact all over the place, right? So you can have a behavior and then you get a thought about the behavior, you can have a feeling and then you start thinking about the feeling. So all these things kind of interact. But it begs the question, where do these thoughts come from? Why do these thoughts pop into our head and so differently for different people? Well, CBT stipulates that there is an underlying construct called a core belief or a schema. Now, think of a core belief as a lens, and we look at the world through that lens. Now, our lenses are built up, you know, they have kernels of them when we're young, they get built up through experience. And when we look at the world through that lens, we tend to see the information that supports that assumption. So I'm going to guess, having spoken to some of you, most of you have pretty good core beliefs, right? I'm, you know, competent, I'm capable, I can handle adversity if it happens, I know how to navigate it. You look back in your history, you can rely on that. So again, you tend to be looking at the world through that lens and you're seeing all of that information that supports it. Now, the people who I work with often don't have lenses like that. In fact, many times, theirs are not so good, right? They have these assumptions about themselves as not being particularly adequate or capable or good enough, or they're unlikable or unlovable, or, you know, they're vulnerable to bad things happening, or even they're a bad person, right? They're not good people in this world. So what happens is they're looking at the world through that lens and they're only seeing the information and data that supports that. Now, interestingly enough, people usually have more than one core belief. You have a predominant one, right? So you have this core belief that you're capable and you're competent, but most people have more than one. So for example, I have a pretty good core belief. I think I'm pretty good at what I do and I'm pretty capable, and if something comes along my way, I think I can handle it. I might not like it, but I can handle it. But if my chief medical officer comes to me and berates me and starts telling me that I screwed up and how could I have done this and what's wrong with me and my judgment was poor and he would have expected more of me than this, what's going to happen? This thing is going to shrink down, it's going to go over here, and then one of these more dormant underlying core beliefs is going to get activated and it's going to pop up and I'm going to think of myself as a screw up, right? I made a mistake, what's wrong with me? You know, I can't believe I did this, and now I'm going to be looking at the world through that lens, and I'm only going to be looking at all the information, how I screwed this up, how I've made mistakes in the past, and then I'm going to act upon that. So again, our perceptions get pushed towards the information that only supports that assumption, we tend to ignore information that suggests that assumption isn't true, or we change information to fit our beliefs. Right? So just to get you to understand this a little better, this is my Pac-Man, and I'm really happy I can speak to people who know what that is, right? So I speak to younger people, they have no clue what I'm talking about, but this is my Pac-Man. And so if this Pac-Man has an underlying core assumption of, they're not good enough or not smart enough, right? Any information that's consistent with that is going to slide right in, right? So it's the same shape as the mouth of the Pac-Man. But anything that suggests it's not true, right, that's the pentagons down at the bottom, is going to be ignored. It doesn't fit, right? For this individual, they can learn things, they have learned computer science, they can fix cars, right? But that isn't consistent with the fact that I'm not particularly smart enough. Now, if the person does notice the information, they will manipulate it to fit their assumptions, right? So, well, yeah, I passed the test, but it was easy. Anybody could have done it, right? It doesn't change my view of things. Now, these core beliefs, like I said before, we have this dominant one, and then we have these other ones that can kind of pop up. It also gives us an understanding as to why some people can do perfectly fine in their lives, have something that takes place, and now all of a sudden they have a major depressive episode, or they're having other kinds of problems, right? Because what happens is that dominant one kind of shrinks down, this other one pops up. But when it comes to treating those folks, that's much easier for me, right? Because I can usually get them back on the path pretty quickly. I just got to get that more predominant one to come back up. People, unfortunately, though, who have poor histories and have had difficult times in their lives, their core beliefs tend to be more rigid and fixed, and this is why they often tend to have more chronic problems throughout their life, and I got to work a lot harder for those people. Now, one of the questions that we have to ask ourselves, how does this happen, right? There has to be some active process that takes place that distorts our information, so we're only looking at the information that supports it and discounting other information. There has to be a process that causes this to take place. And so there is, and we call this cognitive distortions or errors in information processing that people engage in that keeps their attention focused only on the information that supports their assumptions. So they engage in things like all or nothing thinking. I'm either a complete success or I'm a total failure. There's nothing in between, very black and white. But can't you be a success and maybe have some failures or things that didn't work out along the way? What about things like becoming catastrophic? This is the most horrible, worst possible thing that could ever happen, and I will never be able to survive it. They will engage in things like discounting positive information, and they will engage in emotional reasoning. And we see emotional reasoning quite often with people who are suffering from depression and anxiety. And what emotional reasoning is basically if it feels really, really bad, it must be bad. So they're relying on how they feel to justify what they're thinking. The problem is that a lot of times their feelings are coming from what they're thinking in the first place, right? So if I'm thinking that something terrible and horrible is going to happen, I'm going to be really anxious. Now I'm going to use that anxiety to justify what I'm thinking. But that's a problem. That's actually circular logic, right? Tautological logic. So as a result, often with these people, we have to get them away from using their feelings to justify their assumptions, and we have to use more valid and reliable data, which I'll show you in a minute. People get also involved in fortune telling. I know what's going to happen and it's not going to be good. They'll magnify certain information, minimize other information. They will get involved in mind reading. I know what people are thinking and it's not good about me. That's the person who was going to the party, right? They'll personalize information that has nothing to do with them, and they'll get involved in shoulds and musts, right? So these are the types of distortions that people get involved in that, again, keeps them wedded to their underlying core belief. And by the way, those underlying core beliefs are not just thoughts. They come packaged, right? They come with memories, thoughts, visceral reactions, feelings. So a core belief, when it's activated, is really hard to discount, right? So when people have negative core beliefs, it's very hard for them to believe it's not true because it comes in a package. Now, most of us, if we're feeling crummy, we don't like it, right? I don't think Any of you like walking through the world feeling incompetent or incapable, or that people don't like them or love them, right? It's a bad way to walk through life, and most of my patients don't want to feel that way. It's terrible. So in order to keep themselves safe, in order to protect themselves from that underlying assumption, they will create rules. We call those conditional assumptions, but basically they will create rules. And if I follow this rule, then that underlying belief about myself is not true. So if I do this, I am capable. If I do this, I am likable. If I do this, I am competent. So they get things like, well, if I never get sick, ever, never have a symptom, nothing, then I'm not at risk for dying a horrible death from being sick. If everybody likes me all the time, then I'm clearly likable or lovable. And if I do everything perfect all the time, I'm clearly not a failure. Now, you're probably looking at these and you're already understanding the problem with this, right? These rules tend to be very, very rigid and very, very inflexible. And so as a result, they're very easily violated, right? So all I have to do is be exposed to somebody who has a cough, and now all of a sudden I think I'm going to get sick and I'm vulnerable to dying. So what happens is, here is where we start to get those thoughts that start to get emanated from all of this. So basically, I get exposed to somebody who's a cough. Oh my God, I'm going to get sick and die. Or, I'm being invited to this particular party, but I'm going to make a fool out of myself and they're not going to like me, so there's no way I'm going. Or, I get assigned a task at work and immediately I start thinking, I could fail at this and I'm going to screw this thing up. So here come those negative core beliefs, and this is kind of where it comes from, right? You get that underlying core belief, you get these rigid rules, and then you start getting these thoughts that emanate from it, and from that, you get your behaviors, the strategies I'm going to do to try and attempt to stay safe and prevent these negative core beliefs from being true. So again, if I think I'm going to get sick and die, I'm going to wash my hands all the time, right? Keep myself nice and clean. If I think that I'm going to make a fool out of myself, well, I'm not going to the party. I'm going to figure out a way to get out of it because I'm not putting myself in that position. Or if I get assigned that task and I'm afraid I'm going to screw it up, I'm just not going to put myself in that position. I'll just procrastinate. I'll just avoid doing it to make sure that I don't put myself in the position of making a mistake. Now, we call these behaviors safety behaviors because we know why people are doing it, right? They're trying to stay safe. The problem is these things backfire. Now, why do they backfire? Because they actually only reinforce the negative assumption. So let's take the hand washing. So I'm afraid I'm going to get sick. So I wash my hands, right? Now, every time I wash my hands, do I feel better or worse? Better, right? My hands are nice and clean. But every time I wash my hands, do I think the world is a cleaner place or a dirtier place? Dirtier, right? Then I end up feeling what? Anxious. And then I have to wash my hands, all right? So that's the problem. The problem is that we know why they're doing it, but in the end, it only reinforces that assumption, right? So if I avoid going to the party, does it make me think more that I'm going to make a fool out of myself or less, right? If I avoid doing a task, is it making me think more that I'm a screw up or less? That's the problem, right? So you can see how this whole thing kind of gets put together and how we think and we understand human behavior and why people struggle with things when they have these negative, distorted views and ideas. Let's apply this now to some common conditions that we see. So for example, anxiety. So people who are anxious often have underlying core assumptions of vulnerability, helplessness, fragility. Right? They often have rules which stipulate that a bad thing can never happen. Because if a bad thing happens, I'm not going to be able to handle it. I'm going to fall apart. Right? So, for example, I had this individual who I treated not too long ago, came to me, was very anxious. And they had this negative automatic thought that kept popping up into their head that they were going to lose their job. Now, there was no indication that they were going to lose their job, but they were constantly afraid that they were going to lose their job. They engaged in catastrophic thinking because if I lose my job, I'm going to lose my income, I'm going to lose my house, I'll never be able to get another job as long as I live, I'll lose my family, right? Very catastrophic. And engaged in a lot of fortune telling, always looking for evidence that suggests that the next step was going to be him losing his job. So what did he do? Well, he worried all the time, ruminated all the time with these negative thoughts that came in their head, and then he engaged in a ton of safety behaviors, prevention behaviors. He drove his manager crazy because he used to go in and just seek reassurance. Is everything okay? Am I okay? Am I going to lose my job? Is this company okay? He was a workaholic because I must be working all the time to prove to the company that I'm valuable. Of course, he was driving his family insane. He was never around. But again, this was what he was doing. Now, if we take somebody who is depressed, they have a little bit of a different underlying core belief, right? They have one that they're failures, they're losers, they're defective, they're helpless and hopeless to make any changes to any of this. And they often have these underlying rules to try to refute those negative attributes or their inabilities. So I was treating somebody who was a parent, and they had this rule set up for their children in their head that if my child never does anything wrong, right, they're perfect all the time, I'm a great parent. If they make one mistake, I'm a terrible parent and I'm a terrible person. So they had these negative automatic thoughts that other kids don't ever get in trouble, only mine, even though their kids didn't get in any more trouble than any other kid gets into, but, right? That other parents are better than me, that I'm a failure as a parent and a person, and she engaged in a lot of mind reading. I know what the parents are thinking about me. It's not good. They think I'm a terrible parent. So staring at my kids all the time and making, critical judgmental comments about them. So she felt angry, defeated, depressed most of the time. And she engaged in several different safety behaviors. One, she avoided any other parents because she wasn't going to put herself in the position of being judged. And she was very critical and judgmental of her children because they needed to be perfect so that she wasn't defective in some way. So this is an idea, again, my attempt was to try to give you an understanding of looking under the hood of CBT and how we conceptualize human behavior, because this is really the hallmark of CBT. I have to be able to understand people from this perspective so then I can do something, right? Because now I have lots of entry points to come in and try to help somebody. I can help modify their behavior. I can help change and hopefully modify their automatic thoughts or the rules that they're applying or the underlying core beliefs, which all of this is coming from. So there's going to be lots of entry points. So from a cognitive behavioral therapy treatment approach, when we do therapy, it's a very active approach. We don't sit there and go, geez, I know how you feel, right? We're in there. We're trying to help teach people things and try to give them skills. We're very collaborative. I don't come in and tell people that what they're thinking isn't true. What we say is, let's figure out whether your thinking isn't true. Let's see if this thing makes sense. So we try to do it along with them. We're very empathic. Some people I've heard talk about CBT as if we're robotic. We're not. It's therapy. We're very warm and accepting. It's very present focused. So although I was talking about history and that information when it comes to the conceptualization, we have to help people now, today, with the things that they're struggling now. So yes, we need history to understand it, but we work in the here and now. It tends to be time limited because what I want to do is give people the skills to be able to manage this and send them on their way. In fact, at Summit, we have a length of stay limit of 10 sessions. That's it, 10 sessions. I will tell you that the modal number of treatments hovers around 7. So we're pretty good at getting in, identifying what needs to be done, and treating it effectively and moving people on their way. If they need more, we'll navigate them to appropriate resources, but the vast majority of them don't. So it's very effective. And again, we don't take things as just true. That's the problem, right? So if I have this belief, it must be true. If I have this thought, it must be true. We take all of these things to be tested. Let's figure out whether this is true. This is the power not of positive thinking. I have some people said it's the power of positive thinking. It's not, because I think this is distorted as negative thinking. Both are going to get you in trouble one way or another. This is about helping people to see things as clearly and realistically as possible. Then they can make good decisions and navigate the world well. And we love homework, because people don't get better by sitting in front of me. People get better by what they do outside of the session. That's where the real change takes place. So I have to make sure that people are doing things outside of the session in order to get better. So let me also tell you that CBT, through all of its randomized controlled trials, has shown that it's effective for a large range of psychological and psychiatric disorders. This is just some of them. In fact, one of the fathers of cognitive behavioral therapy, his name was Dr. Aaron T. Beck, and I was lucky enough to have training with him. He lived till 100 years old, and up until his death, he was still doing research up until his last breath, basically. And he, in the last 5 to 10 years, he was treating people with severe schizophrenia, so a severe psychotic disorder, which is considered chronic, and he was able to prove that through CBT, he could reduce the number of hospitalizations these people have and improve their ability to function. So again, it's very effective in lots of different disorders. There's also a ton of treatment interventions. There's lots of them. This is just a small little list of them. But CBT, a lot of times, and I do believe this is true, we're cannibals. We don't care that much about the intervention as long as we can affect change in behavior, thoughts, the rules, and those underlying assumptions. We'll use anything. It doesn't make any difference. Now, we have some standard things that we use. I'm going to show you a couple of them. But again, it doesn't matter to us. If it affects change in what we're looking for, then we'll use it. So, and before I get to these other two, I'll give you a quick example. Panic disorder. So if you know panic disorder, it's a terrible experience. Most people with panic disorder think they're having a heart attack. They usually end up in the emergency room a couple of times before they're being told that it's panic, and they start to believe it. And so when people come to us for panic disorder, what they want is the panic to stop. I do not want to have this to stop. So there are treatments out there that work to try to get the panic disorder to stop. I'm going to tell you now, it doesn't work. It fails. Because I can't guarantee you're never going to have these symptoms again. So the most effective treatment for panic disorder is something called interceptive exposure. And interceptive exposure means that I take patients, I bring them into my office, and I induce panic attacks. I can do that. I know how to do that. So I actually have them have panic attacks in my office, not to try to get used to it or get rid of it, to show them that they can handle it. They can manage it. They're capable of it. They will not fall apart. And so I can treat panic in just a few sessions by reducing this panic attack and getting them to be thinking differently, because it's a cognitive intervention, right? Because if I can get you to be thinking like these symptoms are irrelevant, it makes no difference. In fact, can any of you think of times when you can have panic symptoms and you think it's good? Heart racing, sweating, maybe a little shaky, increased respiration. Anybody? Getting really angry on the golf course? Right, that's one, right? Right? Working out, right? If you work out really hard, running, sex, right? We don't think these things are bad. Right? We're interpreting the symptoms differently. So in interceptive exposure, where we get people to be exposed to these symptoms and start thinking about them differently, then it becomes a non-event. It's not, geez, I'm going to go to the mall and have a panic attack and oh my God, what's going to happen? It's, I might have those symptoms and it doesn't matter. So again, by the way, do you know, I'll tell you this, the number one barrier to patients getting the number one most effective treatment for panic disorder is therapists. And I have this problem with my own therapist, and I have to train them in this. Because therapists sit down with their patients, and they say to them, these symptoms won't hurt you. It's fine, right? They're just the sympathetic nervous system coming on. They give all these explanations. It's fine, it's not gonna hurt you. But no way in hell are you gonna have a panic attack in my office because I don't know what the hell is gonna happen. What? Right? So, therapists can be hypocritical. So I have to train my therapist to not only do this, but to do it in the office with them. And I tell you, I've been doing this for about 25, 30 years. I've never had one problem, not one. So again, let's talk a little bit about a few of the other interventions. So this is a very common strategy that we use in cognitive behavioral therapy. This is called a thought record. And basically, what you're doing with this is you're trying to help people to evaluate their thinking to figure out whether it's true or not. Now, I utilized this with a patient some time ago. They were 45 years old, and she was suffering from major depression, and she had a belief that she was a failure, incompetent, incapable at work and in relationships. She had depressed mood, she was tearful quite often, and she had anhedonia. If you don't know what anhedonia is, it's a symptom of depression, which is loss of pleasure. It doesn't sound that bad, it's awful, right? Because if you think about walking through your life every day and it's gray, there's nothing, right? It's a terrible symptom to have. And she felt helpless and hopeless to make any changes in this. So what I said to her was, I said, look, can you give me an example of a time where you either felt depressed or more depressed? And what she said was, well, she's working on a project at work, and she sent a notification to the person she was working on this with, and they never got back to her. And she pinged them a couple of times in between, and they still never got back to her. So I asked her, how did that make her feel? And she said, sad, despondent, depressed. And then I asked how intense were those feelings, and she said at an 85, so it was pretty bad on a 0 to 100 scale. So then I asked her, what was she thinking? What was the automatic thought that was popping into her head? And she said, well, they think the work I've done on the project is poor. They don't want to work on the project with me anymore. They think I don't know what I'm doing, and clearly that's an indication that I'm a failure. And I asked her how much she believed that thought on that 0 to 100, and she said 90. Pretty strong belief. Right? So here's what I said to her. I said, look, maybe you're right. Maybe you don't know what you're doing. You're relatively incompetent. This person doesn't want to work with you. And it indicates that you're basically a failure. I always do a dramatic pause. Or maybe you're just thinking that. And these are two very different things. And from my perspective, I'm going to help this person either way. So if you're not competent, I'm going to figure out a way to help you to become more competent. On the other hand, if you're just thinking this, I've got to get your head screwed on straight. I got to get you to be thinking more clearly. And so I said, would you be willing to spend a little time to evaluate that? And she said, sure. So then what I did is I did a series of Socratic questions. Now, all of you know what Socratic questioning is, right? When these are questions where you're trying to elicit somebody to think through something so you can try to get to some understanding of what is the underlying potential truth of this. So I asked her, these are very common questions that we ask people, such as, what makes you think the thought is true? Because, there's always evidence that suggests it's true, but what makes you think the thought is not true? Or what is the worst possible thing that could happen if, in this situation? And if it did happen, what would you do? How would you handle it or manage it? What is the best possible thing that could happen? And now, what is the most likely highest probability outcome in this situation? What would happen if you keep thinking that same thought over and over again? What if you changed your thinking? And what would you tell a friend who came to you with the same thoughts and feelings, the same situation, what advice would you give them? Now, there's a reason why we ask these questions. The first one is just to collect raw data, right? Let's let the thought sit there and on its own merit, let's look at evidence for, evidence against, and see where it holds up. The other one is really looking at statistics, right? So you guys know about the bell-shaped curve. You know the tails of a bell-shaped curve never touch the baseline because you can never say no to anything, but as you go out further, 2, 3, 4 standard deviations, it gets less and less likely. So again, people often confuse probability and possibility, especially when they're struggling. They engage in sort of investing in possibility rather than probability. So I ask her, what's the worst possible thing that could happen, right? That's pretty far out there, but let's think about that. But what would you do if it happened? People never think about that. They're only trying to prevent it. But what would you do if it actually happened? How would you handle it? So I'm trying to get the person to learn how to cope with these things. What's the best possible thing that could happen? Because nobody ever thinks of that, right? And now, what is the most likely, highest probability outcome if I was a betting man, right? 2 standard deviations accounts for about 98% of the variance, right? What is the most likely outcome that was going to take place? Again, we're looking at this question because we want them to show them the impact of your thought, right? The thinking impacts how you feel, how you see the world, how you behave. And if you change that, that can have another huge impact without changing anything else. And we're trying to get objectivity. You guys probably know that you have great advice for other people, don't you? Great advice. Somehow, it just doesn't apply to you, but great advice for other people. Everybody has great advice for other people, right? And not only that, their advice is usually pretty good, right? Why? We take the emotion out of it. We're objective. So again, we're trying to get this person to become more objective when we ask this question. So I asked her several of these questions. I'm not going to go through all of these, but we just first, like, what data do we have to suggest that this person's thought was true? Well, she hadn't had any contact with this person, even though she reached out to them. She's had some glitches, some trouble on the project. She wasn't feeling very sharp because she was depressed. She had a history, not on this project, but on other projects, where she's made some mistakes and she's been spoken to. She knows others who have gotten in a lot of trouble for messing up on projects, and it makes her feel bad, right? That's that emotional reasoning. But what suggests that it's not true? Well, she has a good relationship with this person that she's doing the project with. She's had no negative comments from them. She's presented good ideas, and she's been told she's been doing a reasonably good job. The person's always been willing to meet with her. She doesn't have the powers of mind reading. She's very bad at that. I'm very bad at that. I've been trying for years, but I'm very bad at it. And so also she can't engage in emotional, just because it makes her feel bad, it doesn't mean it's true. I also asked her that probability versus possibility piece, which is, what's the worst possible thing that could happen? And she said, well, they're not going to want to work on the project with me and think I'm incompetent. And I said, what would you do if that actually turned out to be the case? And she said, well, I'd try to get myself on another project, I'd try to prove myself, and in the worst case, if they lost their confidence in me, I'd go get another job. And I said, could you get another job? She goes, yeah, I can do that. I don't want to, but I could do it. What's the best possible thing that could happen? Well, the person was busy and couldn't get back to me, and they liked my work. And what is the most likely highest probability? Well, they were busy, may have had some circumstances, some criticisms of my work, but still thinks I'm competent and wants to work with me. Now, after we spent time evaluating this, I asked her, was that thought more true or less true in her head? And she said, well, it seems less true to me. I said, okay, so now what is a more reasonable way to look at this if this doesn't seem to be as true? And she said, well, I don't really know why, they haven't gotten back to me, and it doesn't necessarily mean they're unhappy with me or that I'm a failure if they are. And if they are unhappy with me, then I can try to work it out with them, and it doesn't necessarily say anything negative about me. I asked her how much she believed that. She said, at a 76 on a 0 to 100, which isn't bad. And then, did her mood improve? She said, yes, it dropped to a 45 on 0 to 100. And how much did she believe that original negative thought? She said at a 50. Pretty good for 15 minutes worth of work, right? By the way, we actually found out that woman went out on disability. So that's why they weren't getting back to them, and they just didn't know it. Which is always great, because when they come in and they tell me that, I said, oh, so you were wrong, right? So I love pointing things out when you're wrong, right? Because usually it's something that they were thinking that was making them feel terrible. Now listen, I'm a really good cognitive therapist. You know why? Because with all this good work that I did with this person, I know when I send them out into the world and they go back to work and they sit at the computer, right? And they start thinking about this person, I know what they're gonna do, right? They're gonna think, oh my God, the person doesn't want to get back to me and thinks I'm a failure and I'm incompetent. Why? It's a negative automatic thought. It's gonna pop in there, right? We expect that. So for homework for this person, what I did was I said, you're gonna read all the data that we collected every time that thought pops into your head. Because what we have to do is we have to throw this valid data at that negative assumption over and over and over again. And what we're doing is we're just poking holes into that thought so that eventually it becomes wispy and ephemeral, so that when it pops into her head, she can more easily just kind of ignore it. Okay, that's a cognitive intervention. Let me real quickly show you behavioral intervention, and then I'll stop boring you. This intervention occurs a lot with people who are depressed, but even people who are just feeling badly. So when we start to feel down, depressed, or even just badly, most of us end up doing less and less and less. And as we start doing less and less, we end up feeling worse and worse. And then, we end up doing less and less, right? So it becomes a vicious cycle. So what we actually know is that if we can get people just up and doing things again, we can actually get symptom relief and a reduction in what they're struggling with. So here's the question that I ask patients, and you can think about this yourself. What is it that you're not doing now that you were doing when you were feeling better? What is it you're not doing now that you were doing when you were feeling better? And when I ask people that question, they can spit it right out. They know immediately, right? I was walking, I was exercising, I was going to the gym, I was playing golf, I was socializing, I was knitting. It just spit it right out. And so what we need to do is get people up and doing those things again, and we can get improvement. But here's the kicker. People would rather stick red hot pokers in their eyes than do the very thing that they know would help them to feel better. Why? There's no motivation associated with it, right? So people think, I have to get motivated, I have to get pumped up, and then I'm gonna go do something. Research doesn't support that. What the research supports is you have to do something, and then the motivation comes later. For those of you who go to the gym, think about that, right? When you're going to the gym, you go, you wanna go, you're looking forward to go, but stop for a couple of weeks and you don't wanna go, right? It's like, you gotta drag yourself there. So what we try to do to help people to get over that hump is I ask them this. So, let's assume that, we agree that you're gonna go do that thing. Let's say it's going to the gym. And so you drag yourself there and it's terrible. You hate it. It was an awful, you hated every second of it. It was painful. Now, at the end of the day, when you get into bed at night, are you gonna feel better if you did that thing or worse, even if it sucked? And everybody tells me, I'd feel better if I did it. So that's what we try to get people attached to in order to start doing this. I don't promise them they're gonna feel better. You'll feel better later, but you gotta be doing it for a while. So again, when you get into bed at night, will you feel better or worse? And everybody says better. So again, once people start going, they start to feel better, they start going more, and then this becomes, again, a positive cycle. In fact, can anybody think of a multi-billion-dollar company that developed their slogan based on this? Nike, right? Just do it. They don't tell you, let's get pumped up and motivated and then go do it, right? They say, just go do it. And if you actually look at their advertisements, they usually show people sweating and grunting and looking like they're in total pain, but then very satisfied at the end. Okay, so that is a behavioral intervention that we use quite often, especially with people who are depressed. So I hope that I let you see under the hood a little bit of CBT, because that was really my goal. I want you to understand kind of what the conceptualization is and how we think about people, so that leads us to the interventions that we do. So we explained human behavior, try to give you an idea as to how we affect change, what it's used for, and gave you a couple of interventions. So that's it. Open to any questions.
Thank you very much, Dr. Korman, and now we will have some questions for you.
Thank you. That was very, very good. Thank you. So we're all amateur CBT practitioners, with our kids, our neighbors, our friends, our wives, whatever. And I think I speak for the crowd here, but we tend to give snappy answers like, get over it, or just keep on smiling. We sang a song about that today. Or ignore her, she's an asshole. Or this is a good one. You think you got problems? Let me tell you. So the question is, what are the takeaways from your perspective for all of us who encounter these amateur CBT and issues in our own lives? And I just gave you several. You can say, don't do that.
So the quick, snappy answer is, how many times has that ever worked? It doesn't work, right? It doesn't work primarily because most people are in distress. Their thinking is distorted, like I said, and giving out those kind of like just quick answers doesn't do anything, right? In fact, I say that to my patients all the time when they come in and, I'm working with them and they tell me what people are saying to them. And, I said, well, if that worked, you wouldn't be here, right? So my advice is you talk with them about what is going on in your head. What are you thinking? What are you worried about? What are you concerned about? And be curious, right? So tell me, why do you think that's going on? Why do you think that's true? Listen, did you have any ideas as to maybe that might not be the case? Right? Often with my wife, when she comes to me with upsetting things, I will, come in and I'll start asking those questions, and, and she'll say, stop using that cognitive behavioral therapy crap on me. So sometimes it works, sometimes it doesn't.
Let me ask a quick question myself. I used to offer advice frequently because, as you said, we all have good advice for others. And lately I've become more of what I consider a good listener, where I listen and I say, yeah, that must be bad. What do you think about that good listener approach when we have people who are obviously in some kind of cognitive or emotional distress?
Well, listen, you can never be listening too much, right? Being a good listener is great. This is why I also, put into my presentation that we're empathic, we're collaborative, we listen. You have to listen. I think most of you know, and I'll speak for myself as well, when someone's talking to you, how much time are you listening to that person versus how much time are you thinking about a response? Research shows that about 80 to 90% of the time you're thinking about what you're going to say back and you're barely hearing what the person says. So I agree with you. Just the act of listening to somebody and sometimes just reflecting back to them what they're saying can do so much, because when you just reflect back what they're saying, they sit there and they go, wait, that doesn't sound right. That doesn't make any sense. So I agree with you. Doing that alone can have a very big impact. It can.
What a great presentation, Doctor. I promised in my mind I was never going to do this, but you led me to it. You probably, a lot of you know, some of you know I'm an attorney, and I can't tell you how many times in my marriage I heard, "Don't cross-examine me." We're not in the courtroom. I have two questions. You mentioned it. Does behavioral modification still exist as a common procedure? And the other thing I was fascinated to hear is that you've had some success with schizophrenia, and because when I used to know a little bit about it, people thought the only thing they could do was treat with pharmaceuticals. Thank you, doctor.
So the first question on behavioral. So when I first originally got trained in CBT 30 plus years ago, it wasn't called CBT, it was called cognitive therapy. And because we were focusing on people's thinking. It changed to cognitive behavioral therapy, so there's a B in there. So behavioral modification is part of CBT, right? Because what we're really trying to do is we're trying to affect behavioral change. I want people to be doing things differently. So, behavioralism is an absolute part of CBT, and there are people who would not consider themselves cognitive behavioral therapists, they would consider them behavioralists. And so they're just going to manage stimulus response. Let's change the stimulus. Let's change the response in the person's behavior, which is still existent today. But I think more people now are leaning towards CBT because between the stimulus and the response, you got a brain that's actually thinking. You have an intervening variable. And if you don't modify that intervening variable, you're not going to get a change in behavior. But absolutely, it's part of it. The second part about schizophrenia, there is no cure for schizophrenia. There isn't. So what CBT does, it does not cure schizophrenia. What it does is it reduces some of the negative and positive symptoms. So it's a harm reduction treatment. So we're reducing some of the harm, which means they don't end up decompensating as much. They don't end up in the hospital as much. They don't end up having to go to partial hospitalizations. They still end up doing that though, because there's no way to get rid of that. It's just we reduce the frequency of it. Mm-hmm.
Let's take a question online. Al Aho, you have a question?
Well, so I've been fascinated by algorithms all my life. And I don't know whether the answer to this question is known, but is the algorithm that the brain uses to convert thought into a mood the same as the algorithm that the brain uses to convert thoughts into actions?
I ain't never been asked that question before. I don't have a clue on that one. I'll have to get back to you on that one. But good question. I have no idea.
I thought that's what the answer would be.
Thanks a lot, Doctor. You took a very complex issue and really broke it down. So that was great for us. A number of years ago, I took a course. It was a landmark education. And their theory was everybody is born perfect. And that at some point in life, and usually early on, that something happens. And that affects them for the rest of their lives. Usually it's some type of trauma. How does that fit into the CBT world?
Sure. So I'll tell you my thoughts on it. I can have one person who has had an awful traumatic experience, just terrible, right? Early on in their life. And they navigate it, they get through it, and they're doing fine in the world. I have somebody who has the same terrible, hard, traumatic life, and their lives are a disaster, right? They have PTSD, they have all kinds of problems. So again, it begs that question, why? In doing this, all the years that I've been doing it, I don't believe we're born with clean slates. I do believe we have genetic predispositions that either make us more vulnerable or less vulnerable to things that happen in our environment. And if we're lucky enough, we are born with predispositions that help to protect us. If we are born with vulnerabilities, we're lucky enough to have supportive families and environments that protect us, right? So I think it's a combination. I think that it's experience, it's history, and it's genetics. And if your genetics aren't good, sometimes it doesn't matter what the environment is, you're going to have problems.
Early trauma. Can never reach the mic. Is there, okay, difference between depression and just being sad? How does that fit in with this?
Depression is a disorder. Sadness is a mood, right? So if we're sad, we're just not happy. It's usually more transient. It doesn't last all the time. Depression has a whole set of symptoms, right? You have depressed mood, you have anhedonia, you have inappropriate excessive guilt, you have hopelessness, helplessness, you usually have psychomotor agitation or retardation, you have sleep difficulties. Like there's a whole list of symptoms. In the DSM-5, which is how we diagnose people, you need, I think it's 6 of those symptoms. They have to be severe enough to be impairing somebody's functioning, and it has to be there for a minimum of 2 weeks. Most people think depression, like you have to have it for a long time. It's only 2 weeks, because depression, when you have it, is really pretty debilitating. So sadness is really just a mood. It tends to be more transient. It's usually related to something that's going on, whereas depression is really a disorder.
Thanks for a great talk. CBT sounds like a recreational drug. I've noticed that people who I know or suspect are having a panic attack, including George Floyd maybe, say they can't breathe, and yet they're obviously breathing. And if you tell that to them, of course, they're in no mood to listen. But is that common, and is there a way to dissuade them from that?
So when people are having panic attacks, real panic attacks, it's very hard to dissuade them from anything, right? Because they're so panicked, they can't believe that they can't breathe, they're gonna have a heart attack, their heart's gonna pound out of their chest. It's a really, really scary experience. So generally, with those people, you just wait. When someone's having a real panic attack, you just wait. It's not gonna last, it will go away in a period of time, which is one way I try to convince people that they're having panic attacks, right? Because they don't last. I have to work with people who, when they're having panic disorder, I have to work with them when they're not having a panic attack. That's the only way I'm going to get them to be thinking clearly. Now, when I do interceptive exposure, as I was saying before, I never tell people I'm going to do interceptive exposure until the day I'm going to do it. Because if I say to you, hey, I'm going to induce panic attacks with you and I'll see you next week, what happens? Nobody shows up for some reason. I don't know why. So what I do is I let them, I explain panic disorder to them, and it's not the symptoms, it's how they're reacting and thinking about the symptoms. And that I'm going to help them to think about those symptoms differently. And then the day I'm going to do it, of course, I don't force it on them. I kind of tell them what I'm going to do, and are they willing to do it? And then let's just do it right now, right? Because again, if I wait, it's never happening. But generally, it's very hard to help people when they're having panic attacks until you can get their thinking changed while they're having those symptoms. Yeah.
Thank you. Very interesting presentation. I have 2 questions. What role does the patient's spouse or partner play in this process? And number 2, have you ever treated anyone who's too happy, too positive, and too upbeat?
I guess the first question is, are you talking about yourself, or is that what your wife wants you to be? So when it comes to families and spouses and things like that, it does have an impact. And for example, when I treat people who have obsessive compulsive disorder, OCD, right? Again, another really interesting treatment is called exposure with response prevention. And what we're doing is we're actually exposing people to the thing that they are most concerned and afraid of, and not letting them engage in that compulsive behavior. So if we just use that hand washing, we actually expose people to things that are kind of dirty, right? Make them kind of rub the floor, rub it on themselves, but you can't wash your hands. Right? Now, the reason we do that, again, is not to get them used to it, but to get them to make the decision that I'd rather get sick than live the way I'm living now. Because OCD is terrible. It steals everything. It steals your happiness, your time. It destroys your whole life. And so you have to make a decision. The decision is, I'd rather get sick. And so we have to rewire the brain by actually doing those things that we don't want to do and our brain tells us not to do. Now, one of the problems I have is when people go home and they're having a compulsive act and, oh my God, I'm afraid I'm going to get sick, what do the well-meaning spouses and families say to them? You'll be fine. Don't worry about it, right? You're not going to get sick. It's fine. Where I want them to say, what if you get sick? What are you going to do? How are you going to deal with it? I don't want them giving them any reassurance. So I often have to work with them to remove those kinds of safety behaviors that they're giving them. And I actually want them to tell them, well, okay, so if you get sick, what are you going to do? So yeah, we do have to pull them in a lot of times with behavior modification, a lot of times with the strategies we're giving them so they don't counteract them.
We have another question online.
Can CBT be helped using chat or Gemini? Can you get information that will help you?
The answer is yes. There are a lot of CBT apps out there right now. One is called No OCD, and there's a whole bunch of them that actually utilize AI and other native programming to help people with the conditions that they have. I just read an interesting article that said that maybe in the next 20 years, my profession is not going to exist because there's going to be AIs that are going to do it. I hope not. Well, I'll be retired by then. I'll be playing golf with you guys. It doesn't really matter. But I do think there is a lot of value in being able to give people online things, AI things, because remember, I want them to be doing things outside of the session. So anything that I can be doing and anything I can give them to support that change outside of the session is going to be helpful and valuable to them.
Thank you.
We each have our own CBT profiles, as do everybody. Yet many of us are trying to raise children. And we're trying to raise children that don't have the same profiles that we do. How does the community in large help these people to raise healthy children?
Okay. So unlike my patient, I think one of the first things that you have to learn about being a parent, by the way, I have 2 kids, they're in their 30s, is you have to be a good enough parent. The research actually shows that if you try to be a perfect parent, that is the kiss of death for your kid, right? So there is no such thing as perfect. You need to screw up. You need to screw up because now you're showing your kids that you're not perfect. How do you handle adversity? How do you apologize for mistakes? How do you do these kinds of things? So actually, we have to get people to understand that this is not about raising perfect kids. This is raising good enough kids, because actually, when we're good enough, we do much better in the world. So I'm often working with parents about normalizing things that are taking place and trying not to get overly anxious about it, because actually, those kinds of things actually teach kids a lot, right? So I'm not sure if that answers your question, but again, that's kind of what I always am trying to get across when I'm working with parents.
I think we have time for one more question, which is online. Craig Sweetra.
Yes,
Unmute and ask
thank
the
you.
question.
Thank you. Does road rage fall into one of the categories that CBT can treat?
Yeah. So, yes, CBT can actually work on road rage. I've worked with plenty of people who have had those problems. Because remember, people are getting into very distorted thinking when people are driving, right? That person did that to me on purpose. I know what they were doing. They're after, people personalize all of this stuff when they're driving, when most people are just driving, you know? What did Carlin say, right? Anybody that's going slower than me is an idiot, and anybody that's going faster is a maniac, right? So, yes, we can get people to be thinking far more clearly when it comes to road rage. One of the biggest problems I see with road rage is that people want to teach somebody a lesson, right? That's not your job to teach them a lesson, right? If they're bad drivers, they're bad drivers. You're not there to teach them that they're good drivers. So you leave it alone. And remember, if you're angry, we don't act upon that. That's emotional reasoning. Just because I'm angry about it doesn't mean this person was out to get me. So yeah, there are ways to do that. Mm-hmm.
Thank you.
Jim, thank you for a fascinating presentation. On behalf of the Old Guard, we have a certificate of appreciation for you. You'll note on the certificate that there is a picture of an orchid, which was adopted as the symbol of the Old Guard around the time of its founding in 1930. Summit at that time was the orchid capital of the eastern part of the country. But we greatly appreciate your being here, and you certainly have covered this field to completion, and it's been an eye-opening experience for us. So thank you so much. And now we thank you with our Old Guard salute.
Thank you for having me.